I'll request the President of West Bengal Academy of Pediatrics, Professor Kalpana Datta, to welcome the experts, the mentors, and the presenters in this Sandhya Pathshala today. So over to you, Professor Datta.
Thank you, Dr. Roy, and very good evening to all of you. And I welcome you all in this digital platform. Again, we have come with another series of cases, and this is one of the Sandhya Pathshala, a case of neurology. And for that, we have a very good experts. We are really happy and honored to have Dr. Professor Apurva Ghosh, who is the director of ICH. And another is a renowned pediatric neurologist from a consultant in Apollo, Dr. Arijit Chatterjee. And the experts are also, mentors are also very good and very active, dynamic. One is Dr. Jashodhara Chaudhary, she is a budding pediatric neurologist, and another is Gunok De, associate professor in Arjikon Medical College. Because of the net issue, I think he will be joining a bit late. And there are two presenters we have. So one is Dr. Bonnie Shen. She is going to present the case first. Then the Dr. Ekta Pal. And we'll request all the who are attendees, please write your questions in the chat box, and whatever the questions. And its motto is to the clinical examinations approach to a case. We will not discuss too much in theory. How to approach a case, that is the motto, because the postgraduate student should know if these symptoms are there, then how to approach, what are the differential diagnoses, how to rule out other causes. This is our aim to run this Sandhya Pathshala. So try to be clinical, more or less. Now I request Dr. Apurva Ghosh sir to say a few words. Then Dr. Arijit Chatterjee will say a few words. Then Jashodhara will start the session with one. So.
First of all, I thank the organizers, especially Kalpana and Dr. Shopon Rai, or rather, I always say Shopon, because he's my close associate for a long time. It's a very good effort to have this Sandhya Pathshala, and because the main advantage is that we are learning from everyone from every college. In our days, when we did MD, we had to go to every college to have clinical classes. Dr. We met in medical college, we met Dr. Shanti Indro and Dr. Pranab Bhaumik. Dr. Pranab Bhaumik we met in medical college, and Dr. Pan in Arjikor. So we met, and Dr. Rafika and Dr. Nazdar. But with this effort, we are all the teachers of all the colleges, our students will be able to learn much better, and the exchange of knowledge that we have through this Sandhya Pathshala is really very good. And I must appreciate the ideas of Dr. Shopon and Dr. Kalpana.
Thank you, sir. Dr. Arijit Chatterjee, say a few words. Then Jashodhara will start.
Good evening, everyone. Thank you for inviting me. I would like to also echo Dr. Ghosh's thoughts about the fact that digital technology has revolutionized the way of learning from what it was 40 years ago, 30 years ago. And there must have been a lot of hard work in organizing these events, a lot of coordination, and thank you very much, Dr. Kalpana and Dr. Shopon, who I know very well. And we should waste no more time and carry on with the event. Thank you.
Thank you, Dr. Chatterjee. Now I request Jashodhara, please introduce the presenter and start the case.
Thank you, madam, and thank you, sirs, for agreeing to be a part of this program. So, without much ado, we would like to straightly go on this case. Dystonia is something in children that we see in our everyday practice. And so today, our postdoctoral trainee, Dr. Bonnie Shen, will present a case of dystonia, and we will discuss how the dystonia classification has changed and how to approach a child when we see dystonia. And there will be at the end few salient points for the clinicians where we have to, when we see a patient like this, how will be, what will be our approach. Now over to Dr. Bonnie, you may start your case.
So is my skin visible, ma'am?
Yes, it's
Hello?
visible. Start.
Okay. Am I audible?
Yes, yes.
Okay. Good evening, all my respected teachers, my seniors, juniors, and colleagues. Myself, Dr. Bonnie Sen, second year DMPDT, Department of Neurology from NRS Medical College. And today I am going to present a very interesting case of dystonia. So I shall start my presentation with this famous quote by Jean Martin Charcot, that symptoms then are in reality nothing but the cry from suffering organs. So in every case of neurology, we must have an approach. First, from clinical history and from examination, we should try to find out the causative organ that is responsible for producing the signs and symptoms. So this is basically what is called localization in neurology. So keeping this in mind, I will start my case. So this is a story of a 13-year-old boy who presented to us with gradual onset progressive imbalance while walking for last 2 years due to some abnormal involuntary twisting movement in his tongue and intermittent posturing of limbs. There was progressive stiffness which has started from his bilateral lower limbs, followed by involvement of his both upper limbs and trunk within only 6 months. The child developed progressive speech difficulty for last 1 year, which was in the form of disarticulation, undue prolongation of each syllable with intermittent stoppage in between phrases, and gradually he became unable to talk and produces only some incomprehensible sounds, though the comprehension towards the spoken and written words was intact. There was frequent opening of mouth with protrusion of the tongue with hypersalivation that gradually made the child unable to eat properly, and the child became wheelchair bound within only 6 months of onset and bed bound within 1 year. But he could turn side to side over bed. There was one episode of seizure which similarly suggestive of generalized tonic-clonic convulsion at the age of 12 years, and the mother noticed poor scholastic performance since 12 years of age. Regarding negative history, there was no history of any self-mutilating behavior, no visual symptoms, no other motor, sensory, cranial nerve or bladder bowel symptoms. There was no systemic symptoms along with, and no history of any intake of any drug for prolonged period. Regarding birth history, it was a single term birth weight was 3 kg, normal vaginal delivery, which was cried at birth immediately, and the perinatal period was uneventful. So this is the picture of the child, which shows that the child was at the age of 9 years, and the child was developmentally normal till he came to us till 11 years of age, and then there was a rapid regression of his motor and language milestone. So regarding family history, it was a first by birth order born out of non-consanguineous marriage. There was no similar illness in the family or any other neurological illness in the family. This is the pedigree chart which shows that the child has a sibling who is 3-year-old girl child who is neurologically absolutely normal. There was no history of any sibling death, no history of any jaundice. So this is the video of the child. All these videos are taken after taking the consent from the child's parents. This is basically shows that protrusion of the tongue with frequent opening of the mouth. This is during the presentation, first initial presentation of the child to us. This is another video which shows that the child is able to write, but there is protrusion of the tongue which was quite persistent during the presentation. There is hypersalivation and opening of the mouth. So this is the video on examination. There is sustained posturing of upper limbs and also the lower limbs, and the child is wheelchair bound with opening of the mouth and intermittent opening protrusion of the tongue. This is examination of the child on outstretched hand, where there is abnormal posturing of the fingers, the toes, along with there is frequent opening of the mouth and protrusion of the tongue. This showing the same. On asking to say something, the child only can produce some incomprehensible sounds, but he could well comprehend. And interestingly, he could play the video games very well. So now what is the phenomenology? So this is a movement disorder. Basically, this is a hyperkinetic movement disorder. And in primary position, that is in rest, there was frequent involuntary opening of mouth with tongue protrusion. There was abnormal involuntary repetitive twisting movement, which was patterned with sustained posturing involved in the upper limb, lower limb, and also the trunk. In voluntary action, like outstretching the hands, the movements are exaggerated. There was no premonitory urge or the movements are non-suppressible. This mainly differentiate it with other movement disorder like tic disorder or stereotyping. These movements are absent during sleep and there was no other involuntary movement associated with. So this movement is nothing but dystonia. So dystonia has been described under two axes as per 2013 consensus
Dr.
guideline.
Dr. Boni, here there's another question. Was there any diurnal variation?
No, madam.
So
There was
that
no
should be-
diurnal variation.
That should be
Okay.
mentioned. There's no, and of
Okay.
course there is any decrease in vision in the night blindness, because retinitis pigmentosa can have a night blindness, and that heart syndrome.
Ma'am, there was no visual symptoms. I have
that you
mentioned
have
that
to
there was no
mention in the
visual
history.
symptoms, night blindness. Okay, ma'am.
Yes.
No diurnal variation. So dystonia has been described in two axes. One is axis 1, which is basically a clinical axis. Here, for the four subcategory was there, like age at onset. Here, in this case, the age at onset is early onset. Then the body distribution. As per body distribution, it may be focal, segmental, multifocal, generalized, or hemidystonia. So in this case, the body distribution is generalized. As trunk is involved, along with the trunk, there is two more body region like upper limb, leg, and also the oromandibular and tongue involved. Then temporal course of the disease. Here the temporal course is rapidly progressive. And next is the associated neurological features. Here the associated neurological features are present, which is basically the motor and language regression along with one episode of seizure. And then comes the axis 2, which is basically the etiological axis. This tells about the etiology, probable etiology and inheritance of the dystonia. So here the inheritance is sporadic as there is no suggestive positive family history, and the probable etiology is secondary. I will come later why it is secondary, and probable etiology is heredodegenerative query metabolic. So why this case is termed as secondary dystonia? This is the pointers, as there is clinical evidence of other neuroaxial involvement along with the progression of the disease, which is sudden and rapid, and the axial involvement, basically the speech affection, early speech affection and swallowing disturbances, and the children with craniocervical dystonia is mostly the secondary dystonia. So we proceeded further the rest of the examination part. The child was conscious, alert, and cooperative. The general examination revealed no KF ring, no cataract, no neurocutaneous marker, no organomegaly. There was regression of motor milestone, language milestone with slight cognitive decline, though detailed cognitive examination could not be done. Regarding speech examination, there was utterance of some incomprehensible sounds only, but with in the comprehension, basically the simple comprehension was intact. Regarding fundoscopy examination, there was no optic atrophy, no retinitis pigmentosa. Slit-like examination revealed no Kaiser facial link, and there was neurological examination, and there was generalized dystonia with extreme lingual dystonia causing intermittent protrusion of the tongue, fissuring of the tongue, and there is hypersalivation. On tone examination, tone is basically variable, but here there is rigidity in sometimes in all four limbs with joint contracture. Sensory examination was normal, deep tendon reflex normal, bilateral plantar was flexion. So now what is the possibility from history and examination? So if we summarize the case, so this will be a case of childhood onset rapidly progressive generalized dystonia, which is secondary dystonia associated with features of neuroregression and seizure. So our localization is of this secondary dystonia is bilateral basal ganglia and its connection. Now, there are a huge list which causes the secondary dystonia, mainly the heredodegenerative causes. It may be autosomal dominant, autosomal recessive, storage disorder, neurometabolic causes like Wilson, X-linked recessive, mitochondrial. Another entity is dystonia plus syndrome, and some acquired causes like medication, toxin, perinatal injury, vascular lesion, any structural causes, or it may be a part of Parkinson disease, or it may be a part of other movement disorder exhibiting the dystonic phenomenology. So in our case, the most probable cause is the heredodegenerative cause. And we must first rule out the heredometabolic cause like Wilson in every case of dystonia. And next probable diagnosis in our case is a heredodegenerative cause like neurodegeneration with brain accumulation of iron. So we then proceeded to the investigation part. The basic investigation like complete hemogram, peripheral blood smear was normal, DCT was negative, RFT, LFT was normal, thyroid profile was normal. Slit lab examination already revealed no KF ring. Ferritin level was low. Wilson workup like serum ceruloplasmin level was normal. 24-hour urinary copper excretion was also normal. We also have done the CSF study which reveals no significant abnormality. TMS, GCMS, urinary GCMS was negative, and also we performed the NCB of all 4 limbs, which was also normal.
Okay.
Now the
Doctor,
neuroimaging.
एक minute. Investigation, come to the investigation slide for the benefit of postgraduates. Why did you go for the acanthocytes? What does it say? And what does it
One of the
rule out?
Ma'am, one of the differential of NBI spectrum disorder is neuroacanthocytosis. So
Yes.
there is basically feeding dystonia, which is not present in our case. But to rule out the presence of acanthocytes, we have done the peripheral blood smear where we try to find out the acanthocytes, but we did not get it. And also the one of the features of
Abital
neuroacanthocytes
hypoproteinemia,
is exactly. Also abital hypoproteinemia, and also the neuropathy is one of the feature. So we also have done the NCB study, which also reveal normal result.
And Madam, CSF study was done because there's glute disorder. So there is
Okay.
one disorder called glute.
And now I'll ask the experts if they have any queries, then you go for the neuroimaging. Till now, the examination part and history. Any queries from the experts, I'll ask Dr. Chatterjee and Dr.
So what are
Sir.
the indications for CSF? Thinking what you did the CSF?
Sir, actually, to rule out any sort of glute disorder in a child who has dystonia, and so it was not likely in this case, but any dystonia we actually have to do that. But so that was one
There
of
is
the
cognitive
results.
decline and one history of seizure,
Decline.
cognitive decline. So we have done CSF study.
Okay, so very nicely presented, Dr. Bonnie. The questions I have before the MRI is discussed is, what would you think about the hypersalivation that you mentioned and you sort of highlighted, as well as the seizures? So what are those? How can you, I know we've got a generalized dystonia, you're thinking about heredodegenerative cause, that is rightly so. So how would you fit in the other, expanded symptoms into this particular phenomenology?
So
Comment on-
basically, hypersalivation may be due to some abnormal movement, involuntary movement, dystonia in the pharyngeal muscles, which can not able to clear the saliva. So there may be hypersalivation.
So this child must have had a dysphagia as well, isn't it? With so much of
Yes, sir.
dystonia.
There is
Swallowing
a
is
feeding
also
difficulty,
impaired.
swallowing difficulty.
So
Yes,
I
sir.
think that is one of the main causes of why the saliva cannot be swallowed, and therefore it is
Exactly,
coming
sir.
out and being hypersalivation. So those are my thoughts. And the seizures, just the one
The
seizure
seizure,
you mentioned.
exactly. There is a history of one seizure with semiology suggestive of GTCS. Seizure may be due to some cortical event, but the exact cause of seizure we could not find. It may be there is a structural lesion. Afterwards, we find that
Okay.
we
So
could not
have you
clarify why there is seizure.
did you think about doing an EEG for that single seizure, or you thought not?
No, we did not perform EEG.
Okay. Those were my questions. Please carry on.
Okay, sir. Now the neuroimaging of the brain. So it shows T1 image. There is no abnormality. In T2 image, there is bilateral symmetrical hypointensity in the globus pallidus with central hyperintensity. FLAIR image shows the same. DWI image also shows the same. ADC is collaborating the DWI image, so there is no true DWI restriction, and this is the coronal image. And GRE image shows the blooming artifact, that is blackish disposition in the bilaterally symmetrical globus pallidus region. So basically, TU2 and FLAIR image reveal the bilateral symmetrical globus pallidus hypointensity with center hyperintensity that indicates the gliosis without any true restriction in DWI. And there was blooming artifact in GRE, so which suggests iron deposition. So this is basically an eye of tiger appearance. So now, after neuroimaging, our probable diagnosis is NBI spectrum disorder. There are a huge list of under the NBI spectrum disorder, and these are basically the childhood onset NBI spectrum disorder. Less likely neuroferritinopathy. It is basically adult onset, but we got the serum ferritin level low. It is also autosomal dominant, which is not present in our case, and unlikely the Wilson, aceruloplasmia, and neuroacanthocytosis, as all the relevant workup had a negative result. Now we further proceeded with the genetic analysis to confirm the diagnosis, but unfortunately we did not get the PAN2 mutation. Rather, we get some other gene with some uncertain significance. We also performed the parental analysis, which revealed that mother has some mutation with similar gene like WSHC5, but there was no phenotypic characteristics, and the father and sibling genetics was normal. So now summarize the case. This is a childhood onset progressive generalized dystonia with rapid cognitive decline. The possible causes of secondary dystonia have been ruled out. MRI brain shows the classical eye of tiger appearance. Whole exome sequencing does not reveal any PAN2 mutation. So there is a genotypic and phenotypic mismatch. And no such improvement. We have started the triple drug regimen of dystonia, as this is a case of secondary dystonia. So first approach should generalized dystonia. First approach should be symptomatic therapy. Triple drug regimen includes basically the anticholinergic, tetrabenazine, and the clonazepam group of drug. And the child is planned for pallidal DBS, though the outcome was not favorable, as there are many other causes, other features and neuroaxial involvement, and there is regression. So now the approach to dystonia, first in such case of movement disorder, first we have to delineate the phenomenology of movement. So dystonia is basically an involuntary abnormal movement which is patterned, worsened by action, and there are some certain clinical features of dystonia. So after stamping it, the movement as a dystonia, we have to delineate the axis features like axis 1 and axis 2. And then we have to find out the red flag syndrome. Like in our case, there is cognitive decline, there is neuroregression and seizure, and also abnormal MRI findings. And then we have to find out whether there is an one-to-one correspondence with a specific etiology or not. If there is one-to-one correspondence with a specific etiology, so then we have to go for a single gene or biochemical testing, as in case of Wilson. If there is a small number of etiology we suspect, then we have to go for targeted gene panel. And if there is association of multiple different genes, then we should go for broad gene panel like whole exome sequencing, as in our case. So basically, clinical criteria of dystonia has certain feature like posturing, which may be sustained or repetitive, dystonic movements, and gesture antagonist, which is a typical feature of a primary dystonia, where sensory tricks are present. The patient tries to touch the dystonic body part to alleviate the dystonic symptoms. There may be other feature like mirror dystonia, where there is doing the repetitive task on the non-affected part produce or unmask the dystonia on the affected part. Or there may be overflow dystonia, that the feature, one of the feature of dystonia, where there is a rapid propagation of the dystonic movement from the affected part to the non-affected part. So basically, there are three terms. One is primary dystonia, dystonia plus, and secondary dystonia. We should must know the three terms. The primary dystonia, basically the dystonia without involvement of other neuroaxis. Early onset dystonia, sensory presence of sensory tics, and in children, leg onset dystonia and craniocervical onset in adult mainly points towards the primary dystonia. And the dictum is the generalized dystonia in childhood and focal dystonia in adults is always primary dystonia. Whether a dystonia plus is an entity where there is dystonia along with other neurological signs, but the etiology is genetic or idiopathic. It is basically a non-degenerative neurochemical disorder where the etiology is basically genetic, which produces dystonia along with other neurological syndrome like dopa responsive dystonia is one of the example of dystonia plus syndrome. And next is the secondary dystonia, where there is a specific etiology or acquired causes of dystonia, as their perinatal insult or any drug history or other neurodegenerative causes. The onset and progression in secondary dystonia is basically rapid and sudden onset. The dictum is the craniocervical dystonia in adult, and the leg onset dystonia in children is more suggestive of a secondary dystonia. The axial involvement is more common in secondary dystonia along with other neurological symptoms. And regarding investigation, we could found the abnormal neuroimaging, organomegaly, and KF ring. So now few points about NBI spectrum disorder. This is basically a heterogeneous group of disorder, and there is a huge list of NBI spectrum. Most common is the PCAN variety. Most of them are autosomal recessive except the BPAN, which is beta propeller protein associated neurodegeneration. This is X-linked dominant, and autosomal dominant is the neuroferritinopathy. So depending upon the age on onset, the NBI spectrum may be infantile onset as is infantile plan, and or it may be adult onset like acellular plasminia, neuroferritinopathy. But the rest of the most of them are childhood and young adult or adolescent onset. So NBI basically an inward error of metabolism, and depending upon the enzyme defect, we can classify it again certain subtypes like coenzyme A synthesis defect seen in PCAN, CoPAN, and phospholipid metabolism defect seen is PLAN, MPAN, iron metabolism defect seen is neuroferritinopathy, acellular plasminia, autophagy defect is present in BPAN, and unknown mechanism seen in Woodhouse-Sakati syndrome. So this is a huge list. First, we have to find out whether it is family history present or not. If it is a positive family history, then we should look at the inheritance. If it is X-linked dominant, then we should consider testing BPAN. If it is autosomal dominant, then we should think about neuroferritinopathy. Then when it is a negative family history or autosomal recessive inheritance, so we should consider the other neuroaxial involvement like presence of retinitis pigmentosa, craniovalvular dystonia, MRI brain showing eye of tiger sign, we should consider PCAN. Whereas neuropathy, cerebellar involvement, we should think about PLAN. Endocrinal dysfunction like diabetes mellitus, low serum ceruloplasmin indicates acellular plasminia, whereas the extrapyramidal syndrome involvement with cognitive impairment points towards the Kufor-Rakov syndrome. Pyramidal involvement and white matter abnormality suggestive of FAHN, that is fatty acid hydroxylase neurodegeneration, whereas some endocrinal dysfunction with hypogonadism, deafness, alopecia, diabetes mellitus, white matter changes, we should consider about Woodhouse-Sakati syndrome. Spasticity, optic atrophy, and cognitive decline can be a presenting feature of MPAN, that is mitochondrial protein associated neurodegeneration. So NBI group having eye of tiger sign, though it is classical for PCAN, it may be found in neuroferritinopathy and CoPAN. And there are studies showing PAN2 negative genetic study with eye of tiger sign as by Heflik, Hartig, McNeil, Kumar, Strecker, and Valentino. So there are also NBI mimickers, like most important is GM1 gangliosidosis and hypermagnesemia. Also we should consider about the NBI mimickers. So this is a MRI approach, certain MRI findings which points to the specific NBI group, like eye of tiger is very much specific or classical for PCAN, whereas cerebellar involvement is classical for PLAN. Alopecia, endocrine dysfunction along with T2 hyperintensity is classical for Woodhouse-Sakati. Brainstem atrophy is classical for fatty acid hydroxylase neurodegeneration. Whereas T2 hypointensity of caudate putamen and thalamus with patchy involvement of basal ganglia is more classical for neurophaetinopathy. Kufor-Rakov syndrome, there is cerebral atrophy, and acellular plasmania, there is cerebellar involvement along with the confluent involvement of the basal ganglia. So my take-home message to this case is NBIA comprises a clinically, radiologically, and genetically heterogeneous group of disorder affecting children as well as adults. The whole exome sequencing could be helpful as for the majority genetic basis has been delineated. Sometimes there is genotypic and phenotypic mismatch could be found, which indicates evolving character of the spectrum with the discovery of the new genes. Eye of tiger sign, though classical but not pathognomic for PCAN associated neurodegeneration, and it could be found in PAN2 negative condition also. And there are different treatment options based on their pathogenesis and clinical radiological finding. So for this, I would be grateful to the patient and the relatives for cooperation. I am also thankful for all the faculties of my department of neuromedicine, the HOD Kartik Chandra Ghosh and Dr. Joshodhara ma'am for guiding me, and my seniors, my co-PDTs, and also my juniors. So thank you.
Thank you, Bonnie, for the wonderful case presentations. I think, sir,
It's
you
an
are the experts. If you have any
excellent,
queries, sir, please.
It's an excellent presentation. Only one part I think is missing. That how did you counsel the family? How did you give the psychological support to the family?
It is very
That
difficult to counsel the family because the child was developmentally normal till 11 years of age, and then suddenly the child has all the motor milestone and language milestone has been regressed. So it is very difficult to counsel basically his mother. But we have anyhow managed to counsel the mother and continuously giving the moral support to the mother.
So how will you manage this case? And some Dr. Patro asked whether there's any history of jaundice. He already said there's no history of jaundice. And
There was no history of jaundice.
yeah, and there is another question by
We basically manage symptomatically
Shutaba
the
Ponar.
patient.
What is the prognosis and how will you manage?
The prognosis is very grave because already there is rapid decline of milestone, and we basically manage the case symptomatically by giving triple drug regimen and by adjusting the dose of the drug. And the child has been planned for pallidal debase, but it is not performed till now because there was also some unfavorable prognosis for DBS. So basically management is conservative and symptomatic.
why did you not use the term Halliburton spat?
Sir, it has been used, it is a term, but basically in new papers and mainly used the PCAN, that is pantothenic kinase associated neurodegeneration. Basically, it is
There's
a
a story
inborn
behind
error of
that.
metabolism.
There's
Sorry,
a
sir?
story behind that because Hitler during the Second World War used those patients
Yeah, that's
for.
what I know. That's what I want to know from this presenter. What happened with Halliburton and spats? This is just a part of history.
Yeah, during the Second World War, I think they used the Nazis made them use the other people, the Jews, as the experiments of their as subjects of their experiments, and so they were later on banned after the World War was over, and that term has been now deleted from all medical literature.
Okay, Dr. Bonnie. So presentation was excellent. I have a few questions. Like, first of all, you did mention yourself, of course, there's been a genotypic phenotypic mismatch. You're thinking your diagnosis is NBIA PCAN, but you don't have the PANC2 mutation or any of the common mutations. So how sure are you about your diagnosis? Knowing this phenotypic genotypic mismatch, as well as you mentioned NBIA mimics. So what would you do in this case? I mean, this boy has a sibling. She's only 3 years old, you mentioned. So the
We
family
have
will be
performed the
asking you,
genetic test.
what would
So we have performed the
what is her
genetic test in the
prognosis?
sibling.
Okay.
So we
And
have done the genetic test in the sibling also, in his sibling, in his
yes,
younger
and
sister, and all the genes are normal. Whole exome sequencing was done. So we
normal
did not
meaning
get uh, any PANG2 mutation, but there are papers showing that even there is negative PANG2 mutation, it can be stamped as PCAN or NBI spectrum disorder. So
even the mutations that were present in the brother, they were not there in the sister?
no, sister, the genetic study of the sister is absolutely normal.
Okay. And your presentation has been of a sort of, what shall I say, a DM level. How much would you, because this is an MD, forum, they are people who are doing MD pediatrics like you've done before. So would you like to just summarize or simplify your knowledge on the PANC or NBIA or PANC mutations without, you've given so much information, but to summarize from the MD level, how much a person should be prepared for during the exam process, in your own
So
words?
basically, first we have to delineate the phenomenology of the movement. First, we have to stamp it as dystonia. Then we have to describe the dystonia under two axes, like I have discussed that. Whether it is a generalized dystonia, what is the age of onset, what is the progression, and what are other neurological features. Then we have to describe it etiological axis also. What is the inheritance, what are the probable etiology. And as we have taught that already all dystonia cases, we must rule out the treatable causes first, like Wilson, like other drug induced causes. So we have to first search for the treatable causes. So these investigation should be towards the diagnosis of the secondary causes of dystonia, and then we
Yeah,
should
Dr. Bunny,
perform
I
the
think,
neuroimaging. Okay.
Dr.
And
Bunny,
as
I
per
think Segawa
neuroimaging
disease
finding,
also to be.
exactly, Segawa disease is an
And that
entity
is very
which
such as
falls under dystonia plus syndrome,
so
which is dopa responsive dystonia. There are certain features of Segawa like diurnal variation, lower limb involvement.
So I would summarize saying that, first of all, of course, the MD student needs to know about dystonia, and they need to know the axis 1, axis 2, like you
Yes, sir.
mentioned. And they need to have a differential diagnosis. It's not always possible to come to an exact diagnosis, but for your exam, depending on the case scenario, know the differential diagnosis of the common things you are suspecting in the child or the presentation. And you need to know the investigations that you need to order in such children, especially now banking on here you highlighted on the MRI, Neuro Imaging, as well as the genetics. And then, of
Yes,
course,
sir.
you need to know some common conditions, particularly emphasizing Wilson's disease and the treatment, and if there are any other conditions that are amenable to treatment. And you also need to know the hereditary sort of inheritance pattern so that you may be able to counsel the family as well as the family members.
Yes, sir.
I think in this case, most important, other than the Wilson's, is the dopa responsive dystonia. And you have discussed about that.
Okay.
Yes, sir.
Yasodhara, you want to add something?
no, ma'am. For the PGTs, would like to say acute onset dystonia. Think of any drug exposure. If there is a history of regression, like in case as the experts and madam mentioned, dopa responsive dystonia always to be ruled out, and other the metabolic causes. And another important thing is the mitochondrial cause. These things are treatable, and storage disorders. Now many therapies are coming up. So these the treatable causes we have to find out. And any child with dystonia, a dopa trial has to be given, irrespective of we find the findings, because often genetic test is not possible in peripheries and other things. So our trial of dopa is always warranted. We start with a low dose and go up to higher dose. So these are the things that a pediatrician should remember.
Any role of deferriprone or any iron removal drugs, any trials being given?
Sir, we found recently an NBI mimicker in hypermanganesemia. There we saw the role of chelation. So these are some mimickers, but there again, radiologically we can differentiate because those show T1 hyperintensity. And here there is T2 hyperintensity. But we found an NBI mimicker in hypermanganesemia, and those children responded beautifully to chelation.
Thank you.
I think we can move to the next case with your permission, Dr. Swapon.
Sure. So over to Jashodhara to start the second case.
So I think Dr. Pranab is here.
So we have got Dr. Birendra Rai also. Birendra is working in UK as a pediatric neurologist. So I would request Dr. Birendra Rai also to give feedback at this end of this presentation.
Okay. So the next
Birendra,
case.
can you hear me? Birendra, can you hear me?
Thank you. Yes, I can hear you, sir. Thank you for the nice introduction. Just to correct, I'm not a pediatric neurologist. Basically, I'm a general pediatrician with a special interest in pediatric epilepsy and functional neurological disorder. I was quite mesmerized to see how ICH has moved up with such genetic diagnosis and such a wonderful discussion. I just joined it in the midst of the discussion, so I'm happy to continue it. I'm really learning from the presentation as well. So let's carry on. Thank you.
Please be here.
So this is not this is not an ICH presentation. This is a West Bengal Academy of Pediatric presentations.
Okay. Okay. Thank you, sir.
So please be there.
Okay. Okay.
So with your permission, ma'am and sir, we can move on to the next case. Is Dr.
Yes,
Pranab
yes.
here?
Yeah. Thank you, Bonnie, for a nice discussion and presentation. It's a wonderful discussion. Now I invite Dr. Ekta Pal. She'll be presenting another case. And I think Pranab has a very bad network, so you will be there. Jashodhara, you will be there. And the
Yes,
experts are
ma'am.
there.
Pranab sir is unable to join due to.
Yeah, I know.
network
He
issue,
rang me and told me his network is very poor. So no issue. We just start presenting the case. Okay.
Okay, ma'am. Should I start?
Yes, you start. Please.
Yes.
Okay, ma'am.
It was perfect before. Make it in a slide share.
Yes.
Yes.
Good evening, everyone. So I am Dr. Ekta Pal, second year PGT Department of Pediatrics of Arjikar Medical College. So I am here to discuss another patient that we came across. And my moderator is Dr. Pranab. He's unable to contact, unfortunately. So I'll be moving ahead with my case. So my patient was a 5-year-old girl child born out of non-consanguineous marriage, presented with dimness of vision for 20 days, followed by headache for 15 days and abnormal behavior for 15 days. The dimness of vision was present for a duration of 20 days. It was acute in onset, rapidly progressive. Both near vision and far vision was affected. Also, initially, there was abnormality in color perception, following which there was absolute absence of vision. It was not associated with watering of the eyes, or redness of the eyes, or any black spots in the vision. Also, it was not associated with any sectorial loss of the vision. There was no relieving or aggravating factors. And also there was no it was not associated with pain during the eye movement, or there was no association with blurring of vision. The child also complained of headache for 15 days. It was acute in onset, gradually progressive over 15 days. It was bilateral, throbbing in nature, and it was not relieved with medications, and there was no aggravating or relieving factors associated with the headache. This child also complained of abnormal behavior for 15 days. This was acute in onset and gradually progressive, such that the child entered into an acute confusional state for 7 to 8 days, during which the patient was unable to identify known people. That is, the child was even unable to identify the parents of the child. Now, with this symptom, the child was admitted at our institute. However, spontaneously, the child had gradually improved during our hospital stay. Also, this abnormal behavior was not associated with diurnal variation. Now, there was no history of abnormal movements or posturing of the body. There was no history of fever, loss of consciousness, nausea or vomiting, frequent fall while walking or loss of balance, abnormal sensations, changes in handwriting, tremor of the hands, weakness of the limbs, involuntary passage of urine or stool, any painful sensation over the trunk, or difficulty in swallowing. Also, there was no history of deviation of the eyeballs, deviation of the angle of mouth, drooping of the eyelids, any numbness of the face, difficulty in chewing, impairment in hearing, drooping of the shoulder, drooling of saliva, loss of perception to touch or painful stimuli, any bleeding from any of the natural orifices, any swelling in the body, any rashes, or there was no history of excessive sweating. Also, there was no history of any trauma to the head, easy fatigability, pain abdomen, paleness of the skin, blood transfusions, pain in the limbs or the joints, abnormal odor in the urine or in the body. There was no bluish or blackish discoloration of the fingers, any respiratory distress or frequent cough or cold. Coming to the history of past illness, now 3 months ago, the child had a history of high-grade fever for 7 days, severe headache for 5 days, and altered sensorium for 2 days. With these symptoms, the child was admitted in a private nursing home and was kept in that hospital for 5 days. However, there was no documentation available. According to the parents, there was no radiological investigation that was done of the child. 2 months later, this child again had another symptoms of left-sided weakness for around 15 days, acute onset, abnormal behavior along with lethargy for 2 days. Now, with these symptoms, the child was admitted in the same nursing home. However, unfortunately, even in this episode, according to the parents, no radiological investigations were done. And in both these cases, the child had spontaneously recovered, because of which the child was discharged. And we did not get, or we could not recover any documentation from this from the patients regarding these admissions. Now, 1 month later, this child was admitted with dimness of vision, severe headache, and abnormal behavior at our institute. Moving ahead with the history, the antenatal history was insignificant. The child was delivered at a private hospital, term baby, birth weight was adequate, and there were no complications at birth. Also, cry at birth was present. And exclusive breastfeeding was done till 6 months, following which complementary feeding was done. Developmental history, according to the parents, all the milestones, that is the gross motor, fine motor, speech, and social, all milestones were achieved adequately according to the peer age group. Child was immunized as per the NIS schedule, and dietary history, it was a normal Indian diet. The family history, the child had no siblings. It was child was born out of a non-consanguineous marriage. There was no history of TB in the family or in the neighborhood, and there was also no history of any other disease. Coming to the socioeconomic history, the child was staying in a pakka house. There was 1 room, and as per Swami scale, the child belonged to the upper lower class. Moving ahead with the examination of the child.
Hello, Dr. Ekta, just wait.
Yes, ma'am.
Any queries on the history basis? Let the experts interfere and ask some questions for the history. First, you tell me from the chief complaints, what are the DDs came in your mind? And then, of course, the experts will ask the questions.
Ma'am, from the chief complaints of first DD, since initially they had not told us about the past history, from the chief complaints, initially we thought the child is having meningitis or meningoencephalitis, but it was very it was not very common because the child did not have fever. So we were initially going towards thinking about autoimmune encephalitis since it was a girl child, or it could be a case of any demyelinating disorders of the central nervous system. Also, we were thinking that the child could have any space occupying lesion for which the child was having recurrent admissions. It could be Wilson's disease, or it could be any kind of vasculitis that is affecting the CNS. And the child could also have any metabolic encephalopathy.
You have given a very detailed history. Yeah, you have given a very, very detailed history. May I ask you that what is the role of complementary feeding in this case?
So in this case, if the child was not
important, if that is not important, do I really need to mention this? Because you cannot go on telling everything of the history, and that will show your skill that what are the important histories that is relevant to this case. And that's what the history is.
okay, sir, then I should not have mentioned.
No, I'm asking the opinion of the house also, that it should be very relevant to the and not if it would have been a malnutrition case, if it would have been a malnutrition case, then it is. But a complementary feeding at the time of birth or after birth has got no relation to this case.
Yes, sir.
Dr. Ekta, I know we don't have too much information on the two previous admissions you mentioned,
Yes.
but there are some symptoms given. So based on the first and second admissions, what is your thought process on a differential diagnosis? Let's forget about this admission for 20 days in your hospital. But 3 months ago, when she had a febrile episode, you mentioned, with headaches and altered sensorium, and then 1 month later or 2 months later, she had a left-sided weakness for 15 days.
Yes, sir.
With abnormal neurology, behavior. So what is your thought process? Because we have to link those two to the present symptoms. So what is your thought process? I know there's no discharge summary, no radiology you mentioned.
Yes,
But
sir.
still, as in your clinical acumen, what would you be thinking about?
So in the first episode, that is the even that happened 3 months ago. So initially we were thinking that it was a case of meningitis or encephalitis because the child had fever, the child had altered sensorium, headache. So there were all the signs and symptoms were supportive of meningitis or encephalitis associated
something
with
like
some infection.
Acute encephalitis syndrome and the
Yes,
different.
sir. Yes, sir. It was mostly in the first episode was mostly hinting towards a case of acute encephalitis syndrome, for which had the child been admitted at our institute, we would have undergone investigations for the same.
No, what
Okay.
were the drugs during that period?
So
Do you
we
have that?
asked, no, sir, we did not get any discharge summary. And according to the parents in both the admissions, there was no radiological investigation that was done. The only thing that the parents said was the child had an IV cannulation done and the child had received antibiotics. That was the only thing that the patients, as in the parents, could say.
And then 2 months later, there was new symptoms, but no fever.
No, sir. 2 months later, the child had one-sided hemiparesis, as in the child had hemiparesis along with altered sensorium and dimness of vision.
Dimness of vision?
Yes, sir. The child had dim, but it was not, when we were asking that, the mother said that the child was unable to see for a very short duration of time, following which there was spontaneous recovery. So they did not think further as to whether to come to a tertiary hospital or not.
So would you say this is a continuation or this is again a new disease manifesting after 2 months?
So going by what the parents had said, there was complete recovery for 2 months in between, because one episode was 3 months ago. Another event was 1 month ago, but in between those 2 months, the child was absolutely normal according to the parents. And the child had even attended school. So I
Okay.
would suggest that this is a new event that had occurred, or it was a sequelae of a previous event which might have gone unnoticed.
Okay, so it could have been that the previous event was infectious, and then the second event might be
Sequelae
something like an
to previous infections. Sir.
autoimmune or para-infectious manifestations, would you say?
Yes, sir, I would say the same.
Okay, carry
What-
on.
Part of the same disease, because it is very unlikely two unrelated disease will present like this. It's a part of the same disease. Now we will have to see that whether it's a relapsing one or not.
Yes, sir. With the third episode, we were more thinking that probably it is a part of the same disease having waxing waning symptoms.
Right.
Go ahead.
So yes, sir. Moving ahead, on general examination, the child was confused and very apprehensive. Decubitus was off choice. The child had a confused faces. Pulse was normal, respiration was normal, temperature was normal, blood pressure was 94/62, which was normal for that age group, and also the hydration status was normal. Anthropometry of the child, there was no sign of malnutrition because weight, height, and head circumference was also normal for the child. On general survey, pallor, icterus, cyanosis, clubbing edema was absent. Also, there was no lymphadenopathy and neck glands were not palpable. From head to toe examination, the child was normal. So considering it to be a case of neurology, so we moved ahead with the CNS examination first. GCS of the child at the time of admission was 12/15. Child was very confused and very apprehensive. At the time of admission, the child was not even able to the child was not orient to time, place, and person, and was not able to follow commands. Also, the speech we could not assess the comprehension, repetition, or naming because of the poor GCS. We assessed for the meningeal signs that was absent, and cranium and spine of the child was also normal. Moving ahead to the cranial nerve examination, the first cranial nerve examination was normal. So on second cranial nerve, that is the optic nerve examination, these findings were when the child's GCS had improved. That is when I have given the findings, because initially we could not assess the most of the examination of the child. So visual acuity was 6/60 in both the eyes. There was both far vision and near vision was affected. Child could not follow our commands. Also, the field of vision could not be assessed. Color vision, child could not see anything. So color vision also could not be assessed. Pupils, they were bilateral reactive to light. Both direct reflex and consensual reflex was present in both the eyes. Blinking response was present, and fundus, all the fundus examination was normal in both the eyes. Also, examination of the third, fourth, and sixth cranial nerve was normal, and rest of the cranial nerve examinations were also normal. Motor system examination, it was all the deep tendon reflexes and superficial reflexes were present. They were normal in all the four limbs. Sensory examination, there was no abnormality seen. There were no cerebellar signs. Gait of the child was normal, and also there was no autonomic disturbances present in the child. Other CNS examination was also normal. So thus, summarizing my case, this is a 5-year-old Hindu girl child, resident of Habra, born out of non-consanguineous marriage with insignificant birth history, immunized up to date, and normal development, adequate in daily calorie intake, presenting with history of dimness of vision for 20 days, and headache with abnormal behavior for 15 days, which was sudden onset, rapidly progressive in nature. Patient has a past history of fever with headache and altered sensorium 3 months ago, followed by left-sided weakness and abnormal behavior 1 month ago. On examination, the child was confused, apprehensive, with the GCS being 12/15. Visual acuity was 6/60 in both the eyes, both pupils being reactive to light. And rest of the CNS examination was normal, and rest of the systemic examination was also normal. So my provisional diagnosis would be a 5-year-old girl child with acute encephalopathy, with cranial nerve palsy and vision impairment, without hearing impairment, without evidence of raised intracranial tension, involuntary movements, having adequate nutrition and immunization status, probable etiology being acute encephalopathy with optic neuropathy, probably due to a demyelinating disease triggered by a previous infection. So should I move ahead?
So please give, yeah, that is the provisional diagnosis descriptive. So would you like to sort of name the conditions that come to your mind from this sort of provisional diagnosis? What are the conditions you're thinking of?
So from this provisional diagnosis, I'm thinking about the demyelinating disorders of the central nervous system. So which include acute disseminated encephalomyelitis. It could be multiphasic disseminated encephalomyelitis. Also, it could be a case of multiple sclerosis. It could also be a case of clinically isolated syndrome or any NMO spectrum disorders. So that is what I would be thinking of.
One thing I'd like to know, suppose the in examination and findings, the one thing is important is fundoscopy. So ophthalmological, was that evaluated?
Yes, sir.
And RAPD, when we see there is whether any relative aberrant pupillary defect. So were those two seen?
Yes, ma'am. They were seen. Ma'am, fundus was absolutely normal. The shape of the size, the cup size, all the borders, ma'am, all the points, they were all normal. We had seen the child, as in the fundus of the child. And also we had assessed if the child was having RAPD, but both the pupils were equally reactive to light, both direct reflex and consensual reflex were present.
You mentioned clinically isolated syndrome or CIS. What is the definition actually?
So the definition of CIS, that is, it's a case of a first monofocal or a multifocal CNS disease where encephalopathy is absent.
And this child already has had 3 episodes.
Yes, sir. And as in, we did not get the documentation, but from the history, sir, the child had 3 episodes.
Yeah, so if a child has had, even without documentation, 3 episodes from the history, then you cannot sort of
yes, sir.
Think about CIS, because by the definition, it's a single incident or episode, isn't it?
Yes, sir.
Okay. So if you can carry on now. Any other questions from the other people? Otherwise, you can please carry on.
Also, when you mentioned MOGAD can be a differential because it presents with encephalopathy, and headache is not usual in multiple sclerosis, but it is more common in NMOSD and MOGAD.
Yes, ma'am.
There are a few questions, unique questions. Can you take that?
Ma'am, should I see the chat and answer?
Yeah, maybe Jashodhara can help you. I can't see the question.
Yeah, one question is acute encephalitis syndrome preceding illness, then neuromyelitis, NMO or Devick's disease, optic nerve sheath thickness. Actually, she hasn't gone into I think that part. And one question from Dr. Bonnie is RAPD present or not, fundoscopy done or not, that she has answered. And examination of spinal cord is another question that has been posted right now. So,
ma'am, we had gone for the examination of the spine, sir. Ma'am, clinically, there was no abnormality seen in the spine.
Okay. And there were no pyramidal signs?
No, ma'am, there were no pyramidal signs.
Okay.
So, in the investigation, we performed the blood investigation initially, but there was no abnormality seen. Also, we performed a CSF analysis of the child, where cell count was normal, the glucose microproteins were normal, and also we performed a viral study, which was also it was non-reactive. We moved ahead with the autoimmune profile in the blood and the CSF, which was also negative. So, thus ruling out autoimmune encephalitis as one of our diagnoses. Also, we sent blood for ANCA and ANA, and both were negative. We performed blood investigations for serum lactate, serum ammonia, blood sugar, and also urine ketone bodies. And all of them were within the normal range. The child was, eye of the child was seen for KF ring and there was no, it was also absent. Also serum, ceruloplasmin, and urine copper, they were also within the normal range. We then moved ahead with the neuro imaging of the child. In the neuro imaging, what we saw was there was hyperintense lesions seen in the gray matter as well as in the white matter. And the report said there was areas of patchy areas of vasogenic edema in the cortical, subcortical, and paraventricular regions. And according to our neurologist, it was suggestive of tuberculomas or disseminated encephalitis. We also performed MRI of the brain with contrast. And with contrast, we saw that there were lesions seen in the cortical matter. And according to our neurologist, radiologist, it was seen that there was multifocal T2 or flared hyperintense areas in the cortical, subcortical locations in different parts of the brain. And according to them, it was a case of demyelinating disorder. We also did MRI of the optic nerve of this child, which showed that there were patchy areas having increased signal intensity. Also, there were slight atrophic changes seen in the optic canals and optic tract, which was measuring around 1.5 millimeters. And there was also optic nerves having increased signal intensity, which was suggestive of optic neuritis. We also performed chest X-ray since there was a DD according to the MRI report of tuberculoma, so we had to rule out tuberculoma. So chest X-ray was normal. We performed MR spectroscopy, which was also normal. And CBNAT for CSF was normal. There was no TB detected. We had also performed CBNAT with gastric lavage of the child, wherein also there was no TB detected. After this, we had sent, so we were more clinching our diagnosis towards a case of demyelinating disorder of the CNS. So we had sent blood for NMO and MOC profile, where the myelin oligodendrocyte glycoprotein was positive. So thus diagnosing our case to be a case of MOC positive acute disseminated encephalomyelitis. So for the management of the child, we had given injection prednisolone IV for 5 days, following which we had given symptom, as the patient's symptom has started gradually, we had given orally. Oral prednisolone was given for around 6 weeks and then followed up, and then the child had gradually improved. The child was discharged and child is currently being seen on a regular basis at our OPD.
Okay, so can I just stop you here?
Yes, sir.
I think they've other people have also queried. Didn't you not think that the MRI of the spine was important at this stage?
Sir, actually, we had performed MRI spine of the child along with contrast, but sir, there was no abnormality seen in the MRI spine.
Okay, then you need to mention it because it's, I think, very relevant. And
Yes, sir.
Somebody did ask about, did you do a VEP study? Because again, that is also relevant.
Sir, we wanted to do VEP study, but at that time, sir, it was it could not be done at our institute. And sir, since the patient was very poor, so we could not get it done outside.
Okay. Okay.
If the patient is so poor, then when your ceruloplasmin level is 42, do you need to do the urine copper in this case?
Yes, sir.
So that was a total wastage of money.
Okay, yes, sir.
For a
I would like to
ceruloplasmin-
also, yeah, sorry, carry on.
Yeah.
So I think so in this case, if you see a kind of demyelination, so we have to obviously do MRI whole spine MRI orbit with the star image or the fat suppressed image and the MRI brain plus contrast. Otherwise, long-term management will differ because it's very important to classify the disease and start the management, not only the acute but plan the long-term management. So now it differs accordingly according to the different protocols and findings.
Ma'am, actually, we had done the MRI spine, MRI brain with optic nerve and spine together at the same sitting. But ma'am, since the findings were seen in the brain, so I did not include it in my slides. I should have done that.
And just one point for the students. If you have a negative autoimmune encephalitis panel, that doesn't mean you rule it out, because clinically there are situations, if you are strongly suspecting autoimmune encephalitis and you have a negative panel, you still confirm or you stick to your diagnosis and go ahead with the treatment. So yes, the panel was negative. In this situation, we were thinking about other things, but it doesn't rule out. A negative test never rules out autoimmune encephalitis in the right context.
It's in 60% cases that you get an antibody positive, but in 40% of the cases, even in autoimmune encephalitis, you don't get any antibody positive. And the other thing is that I think it is better to mention methylprednisolone rather than prednisolone.
Okay, sir.
Yes.
Because prednisolone intravenous is not available.
Yes, sir.
There are a few questions like why Wilson workup was done, that sir also asked, I think so. And another question is there, what other components of autoimmune encephalitis, GI, CVS, whether the manifestations were there. Then,
ma'am, there was no other symptoms of any GI or any other manifestations were not there. The symptoms of CNS manifestations were there. We had gone for a thorough examination of the child, but there was no such symptoms in the child.
I think in antibody negative cases, autoimmune encephalitis and ADEM are really overlapping. It's very confusing. Kiva, what do you think, Jashodhara?
yes, sir. That may be there, but here the other things were there.
I mean, antibody negative. I mean, how do you differentiate between ADEM and autoimmune encephalitis?
So the clinically the thing is that there may be overlapping features.
Yes, that's
and yeah, but the MRI
Uh,
features will help us to differentiate, because
yes, MRI useful.
yeah, MRI is very useful. And again, if we have a suspicion of autoimmune encephalitis, now the protocol only says that if we get nothing also, then also we have to think on the line and start this thing. And EEG, one EEG would have been helpful in autoimmune encephalitis.
Yes.
Actually, we had wanted to do the EEG as well as VEP, but ma'am, at that time at our setting, it could not be done. So ma'am, that is the reason why we as in both of them were planned for the patient, but we could not get that done.
Okay. Yeah, and Dr. Ekta,
yes,
sometimes we might get some clinical features which can give rise to a suspicion of autoimmune, like orofacial dyspraxia or orofacial movements, psychotic movement, which may be absent in ADEM, but in autoimmune it will be there. And of course, as Jashodhara said, the MRI will be
and also focal seizures.
Yes, seizure, focal seizure, auto older age group, female child. But of course, in medical science, anything can happen. Even you have shown one case in 1-year-old child also. So that can happen. But the commonly suspect autoimmune, older child, female child, present with neuropsychiatric disorders, orofacial dyspraxia, and that will give some clues to the clinically to think of autoimmune.
Also, ma'am, in smaller child, as Apurva sir will remember, in ICH we got a child as young as 3 months, when the PET scan ultimately showed all things were negative.
Yeah, I remember we presented that case.
And presented with only hyponatremia and behavioral and seizures. So that was a miracle.
Dr. Nondi has asked, what do you mean by confused facie? I think it may be a printing mistake. Confused facie.
I was also going to ask this question. That what do you mean by confused patient? But because I was confused, so I didn't ask that question.
No, I mean, sir, that is, the child was actually very confused and apprehensive. So
no, that is not the facie, that is the behavior.
Yes, ma'am. That was the behavior. Yes, ma'am.
And another question by Dr. Nondi, another question: how could you examine the first cranial nerve when there's a confusional state, which you won't be able to do? Don't mention. Could not be tested.
Ma'am, actually, some part of my examination, since the child had resolved, the child's GCS had improved after a few days after examination, ma'am. That is when we could have done which I had mentioned, ma'am. That is when
Okay.
we could do the CNS examination. But before that, we could not even assess the visual acuity of the child, because the child was in such a confused state. So we could not proceed with our investigations, with our examinations then.
Okay, okay, good. How you counsel parents justify not doing MRI in the first, second admission? Or someone is, Dr. Rai is mentioned how you counsel the parents and justify not doing MRI in the first or second admission.
Ma'am, actually the child was admitted since they were very poor and they were highly ignorant. So ma'am, they did not get a radiological investigation. Moreover, when they had been told about, that is what the parents said, when they had been told about the cost of the MRI outside, ma'am, they were highly like, we can't afford to do this. And that is why, I know it is very
Okay, okay.
unlikely that even on second admission, the patient did not get an MRI done, but we could not help it actually.
Where was the patient admitted?
So that was a private nursing home. It had a different name, ma'am. They did not have, as in, sir, they did not have any documentation of the admission because they were coming from a far distance.
No discharge certificate.
No, sir. We asked multiple times, but they could not provide any documentation of the previous two admissions.
Okay, how long ago was this presentation? And you mentioned that clinical improvement noted, patient being followed up. So follow-up is for how long? A few months or more than that?
So this patient came to us 1 month ago.
Okay.
1 to 1.5 months ago, the patient had come to us. The child was admitted, and when the patient was given oral prednisolone, as the child had begun to improve, that is when we had discharged. So initially, the child is being followed up almost every monthly.
So
And
child is still on prednisolone?
Yes, sir, but the child is now being tapered off.
Right. Yeah, carry on.
So I would like to discuss ADEM. That is, ADEM is one of the demyelinating disorders of the CNS. It is a very rare autoimmune demyelinating disorder occurring at a frequency of around 0.5 to 1.6 per 1 lakh population. And it is characterized by multifocal demyelinating lesions in the white matter. One hallmark of ADEM is encephalopathy, and there are multiple precipitating events that are present, but it is still controversial. Like in our case, in our patient, probably there was an infection that had occurred at least 3 months ago, following which the child had begun having these diseases. And these are immune-mediated attacks that are occurring on the white matter because of the antibodies that are produced against the brain, optic nerves, as well as the spinal cord. And white matter insulation, ma'am, this is the discussion that I have written in my hands in order to discuss about this disease. So the white matter insulation is formed of oligodendrocytes that is wrapping around the nerve axons. Now there are two antibodies that can be responsible in case of demyelination. That is the profile that we had done, that is aquaporin P4 antibodies and myelin oligodendrocyte antibodies. Now, these myelin oligodendrocytes are exclusively expressed only in the CNS, and they are located in the outer lamellae of the neurons as well as on the cell surface of the oligodendrocytes. Now, depending on the site of location, there are many factors on which the ADEM, as in demyelinating disorders, depend. It could be the location of the neurological.
Lights are not moving.
Ma'am, actually, these I wanted to discuss as in.
Okay, no issue.
So, ma'am, it is depending on the location of the neurological deficit. Any encephalopathy is present or not. In case of ADEM, encephalopathy is a necessity. Also, in case there is any specific antibodies are present, and the disease can be either monophasic or there can be repeated attacks. As I had said, so ADEM, if it is occurring multiple times, then we call it to be a case of multiphasic ADEM. Multiphasic ADEM is diagnosed by any new, that is, there is a duration of 3 months, and any new event that is occurring after the initial event, and there are re-emerging clinical signs or symptoms. So one take-home message would be that is demyelinating disorders of the CNS, they're having a very heterogeneous presentation. Spectrum of presentation is very heterogeneous, and there are very lack of discrete biomarkers for which ADEM diagnosis still becomes a challenge for us physicians. Now, there are overlapping symptoms, because of which there is usually associated with a delay in our diagnosis. So, a high index of the clinical suspicion along with awareness of the atypical features, they are of paramount importance for the diagnosing the disease. And initial early diagnosis, early treatment is better to avoid any neurocognitive consequences and also the fatality of these patients. Thank you.
Thank you, Dr. Ekta. First question after your presentation is, you mentioned that the MOG antibody was positive. So
Yes,
how do you think this will reflect on the prognosis of the child?
Sir, could you repeat? There was a problem in the network, sir.
You mentioned your MOG antibody was positive.
Sir, in 50%, around 50% of the cases, they're MOG positive and 50% are MOG negative. But sir, it does not usually affect the prognosis of the disease.
If it is positive, is it different? Is the prognosis different than if you have a MOG negative?
Sir, I think it does not affect the prognosis of the patient.
It is different than ADEM, right? So you have to plan for a long-term treatment. So sir is asking that, do you plan for a long-term treatment if it is MOG positive or any other sort of treatment apart from steroids, steroid-sparing agents, or any other?
We have to follow up the patient. In case there is improvement of the patient, then we can move ahead with steroids. And also, like in our patient, since there was improvement, so we decided to taper off. But in case there is no improvement, and if there is even deterioration of the patient, then ma'am, we might have to go with monoclonal antibodies or even plasmapheresis of the patient.
So there is a course of steroid. You cannot taper off just like that. So there is a routine course. And how long is that? Do you know that?
Ma'am, we give it for 6 weeks. Oral prednisolone is given for, as in for initial 5 days, we give injectable prednisolone. Following which oral prednisolone is given for 6 weeks, and after that we assess the condition of the child. If there's no improvement, ma'am, then we'll have to move ahead with other treatments, ma'am, which I honestly don't know in details about.
Yes, that is understandable. So MOG antibody, did you check by cell-based assay? Because that is now recommended to check by cell-based assay. And
ma'am, we had sent MOG, serum MOG, ma'am, it was done on the cell-based assay.
And
Okay.
sir, would you like to give any expert comments on the, because she said that she doesn't know that, if you would like to give any expert comment on the continuation of the steroid therapy for a first attack of MOGAD or MOG antibody.
Yeah, so that is the concept that I wanted to highlight. So if you have this clinical picture with a MOG antibody positive, then the new concept is that this is MOGAD or MOG antibody associated disorder. And that would differentiate your prognosis because the relapse rate in such children is known to be higher. And therefore the immunosuppression needs to be carried on for a longer duration, and the children need to be monitored for a longer duration. And the other options of treatment apart from giving steroids is you have to consider with the common thing that we use is rituximab treatment. Yeah.
Yeah, Dr. Purba sir have any questions, sir?
No. I think I was going to ask about rituximab, the fourth option, because there are 3 options. One is methylprednisolone and steroid, and usually 5-6 weeks of steroid is good enough in most of the cases. Then IVIG is also one of therapy, and in some cases plasmapheresis. And then lastly, the rituximab, which Arijit has mentioned, it works in some cases by depleting the B cells, which produces these antibodies.
And while giving the rituximab, we have to give the appropriate dose, Don't give it a lower dose on 375 milligram per meter square, whatever the dose you have to give it. And can we repeat it also if needed?
And you
Yes,
need to
there's
exclude
a protocol.
tuberculosis. You need to exclude tuberculosis before that, before you give
Spinal
rituximab.
cord.
To exclude rituximab.
Yeah, preferably in a ICU setting, medication to be given preferably in a ICU setting.
Dr. Joydeep has asked Dr. Boni has asked any role of repeating MOG antibody.
No, ma'am, there is no role of repeating MOG antibody in case the patient improves. But ma'am, if there is no improvement, we might consider repeating, but ma'am, that will be later.
No, when we decide therapy, there is a role, but it is actually a very difficult question for her. So,
Yeah.
Bonnie, you can answer that yourself if you want to.
Dr.
Yes,
Boni?
ma'am. Actually, we will repeat the MOG antibody after 3 months to show the titer. And based on this, we further plan the long-term immunosuppression.
Okay.
Yes, now there is a role of repeating MOG antibody, and as Sir said, rituximab, we need some investigations prior to that, TB workup, CD1920, preferably the viral negative serology and cytomegalovirus negative serology as well. This is the actually recommended protocol, of which in government hospitals even we can do easily 3 of them. And there are certain rules while giving that, and post rituximab also there are certain protocols. So when you are giving, you should know about that.
And for the
Yashodhara.
students, again, to mention that the MOG antibody can be done on a blood sample. So you don't have to do it on CSF, which is much more invasive. So it's a simple prick to the vein, send the blood, and you can get a report.
Yes. NMO and MOG, they are better in blood samples, and OCB and IgG index for multiple sclerosis, they are better in CSF. And NMDR also, the CSF sensitivity is much more than serum sensitivity.
There's another question by Dr. Joydeep.
What percentage of our population is CMV negative?
Sir, CMV negative.
I mean, this is my question to Yashodhara.
Sir, they have asked to see the titer, sir, not the
Okay.
positivity, the titer, sir.
You mean to say
Yeah,
DNA PCR?
CMV positive.
Actually, it is the way they have recommended, but it is not done here. We do not do while doing that because all are positive, but they have asked to see the titer.
Okay.
Ma'am, one doubt I had, ma'am, when we had sent blood for NMO and MOG profile, ma'am, it was only given as positive or negative, but ma'am, the titer was not given in our reports. So should we write it as in with titer for such a report, ma'am? Do we need to do that?
The normal labs, sir, Arijit sir, if you have any experience, we have seen only positive reports. The titer,
Yes.
many of this, suppose now we have a rule of sending in government, from government institutions and others also, they are not giving the titers, but only positivity.
Yes, ma'am.
But others, some outside labs, they are giving the titers.
Yeah, so it helps if you have the titers. Sometimes you have to repeat later on, but in most cases, we just get it as positive or negative, and we have to deal with it in that.
Also, we get a results are weekly positive. Sometimes we get such results. It's mentioned as weekly positive. So that we do not know exactly the titers, but we have seen reports like that.
Yes, ma'am,
Okay.
because in our patient only positive was given. So I had no idea regarding the titer, if that is available in our labs.
Yashodhara, Dr. Pranab De has joined. If Dr. De has got any comment, he can.
And Dr. Joydeep has one question. Medical legally, every month central vision perimetry should be done.
Okay.
Yashodhara and Arijit, can you clear up little bit about the difference between ADEM and autoimmune encephalitis?
Sir, we
Yeah, well, if I go first and then Yashodhara can add on. Basically, autoimmune encephalitis in children, the important one is the NMDA. And in that you get the behavioral changes as well as the orofacial movements that are very common. Of course, there are other types that can come in the differential diagnosis. Of course, they will also be encephalopathic, and in that way you cannot distinguish between the two of them, because like you said, ADEM has to have encephalopathy. I think for me, apart from the little bit of differentiation in the clinical presentation, the MRI will be helping a lot. The MRI in AIE is more subtle. There are changes in the hyperintensities, but the MRI changes in ADEM would be much more marked to sort of clinch the diagnosis. And then,
Dr. Chatterjee, what is the incidence of delta brush in EG?
Incidence of delta brush?
Because we have not seen lots of cases of autoimmune encephalitis.
Yeah, I wouldn't know that. I wouldn't know the incidence, but I've definitely, we've discussed it, and there are cases where we've seen, at least in India, where the presenters have shown a delta brush. But in my own experience, I haven't come across making a diagnosis on just the basis of a delta brush on the EEG in a case of autoimmune encephalitis.
So we had one case, Dr. Jashodhara, 9 to 10 years old baby, and she was such a having such a neuropsychiatric disorders that she was was getting treatment from the psychiatry department, and when she developed compulsion, then referred to us. And it was a case of autoimmune encephalitis, and we had to give the Ritax 2 doses, and there was a complete recovery. So psychiatric disorder is very important.
Yes, ma'am. And as I said, apart from that, dystonia is another thing, acute onset focal seizures, dystonia and perioral movements going in favor of NMD or encephalitis. And the case in ICH, that was very strange case in a small child presenting with hyponatremia. That is another feature of autoimmune encephalitis. Hyponatremia, and that was resistant hyponatremia, and all the antibodies were negative, and we used PET scan. Now the recommendation has come. PET scan will show specific hypometabolism is in places. So all the children who present with acute onset psychiatric disturbances and land up in psychiatry wards, we have to see that. Another important thing, we recently saw a child who presented with narcolepsy. The child was falling asleep. The child was eating more. That was called the diencephalic syndrome. So that was associated with NMOSD, and many times may be seen in so if a child comes that the child is sleeping and eating, it is not only a behavior problem, but we have to search underneath whether there is an immune mediated pathology inside.
Very good.
Okay, that's a very good discussion. Thank you.
As Jashodhara has mentioned, that doing a PET scan is very, very important in autoimmune encephalitis, especially when it is slightly older child, because it might be secondary to some malignancies. So doing the PET scan will be better. It will, even if your MRI is normal, that will show the metabolic changes in the brain. If there is a tumor somewhere, that will be shown by the PET scan. So doing a PET scan is good.
Yes, sir. And the child in ICH was the eye opener, because the child responded magnificent to rituximab. We don't know the child right now. But it was so beautiful case where she taught us so many things that if we end that, we have to go for further investigations, which are available nowadays.
Jashodhara, I would like to comment a little bit. You know, Kavita chilo. Kavita, it's on the lighter side. Priyadarshini Indira, ভুল করে কখনো তো হেলিকপ্টারে চড়ে বন্যা প্রদর্শনে যেও না, হয়তো মুখ ফসকে বেরিয়ে যাবে বাহ কি সুন্দর. So no case beautiful. So please don't mention that.
No, mane was a learning experience for us.
That's better to say.
But the child sir is now very well, so it is now beautiful.
Anyway, I was joking, but be careful.
So I think wonderful discussion.
So any comments for Pranab and Virendra? Virendra,
Hello.
you are not
Thank you, sir.
visible. You are not visible.
That's okay. Thank you, sir. Let me get visible if it's possible. I think that was a really excellent discussion. Though I touch base my practice on epilepsy and functional neurological disorder, this is slightly beyond that area. But there was a nice learning. What I want to emphasize to the trainees is we are moving towards an era where we are moving from being a dictator towards a facilitator of care. I am pretty sure you all are aware of that in India, litigations and things are all going up as people are getting more matured into these things. As a facilitator of care, providing clinical care is one of the most important things, but alongside, it's also important to provide the psychological support and counseling to the patients. And as Apurva Shah was mentioning earlier in the first case discussion, how the psychological support was provided. So irrespective of the patient's background, I think that's a very important area to discuss how to support the parents during this diagnosis, especially where the impact on the life of the child and the family dynamics is going to be disturbed for some time. So psychological aspect of the care also needs to be given consideration. Which we see quite a lot in Western countries where you have a separate team coming to help you out there. And hopefully, I think in India, as we move towards being a facilitator of the care, this thing will prop up. That's all from my side. I think the discussion was excellent. I learned a lot.
Thank you, Dr.
Thank you, Virendra. And I really appreciate your presence and also appreciate your presentation, that the way you present nowadays and the way you used to present when you did MD under me. It's a hell and a heaven difference, and it's a dramatic improvement. Shapon, what do you say about that?
Actually, yes, you are absolutely right. In fact, we are in a learning process also, and I'm really surprised to see the height of the level they are presenting. The Bonnie and the Ekata and our experts are excellent. You would be on comment, but Joshodhara, I think I missed Pranab also. So Joshodhara is excellent. So in fact, it's a learning process. So Pranab, are you there? Please make your final comment.
Yes, sir. Good evening to everybody. I was sorry for a little bit. Because of the poor network, I has joined later on, but I have really delighted to be a part of this program, and I am really enlightened by the intensive discussion. I just want to mention here that this is a very good, I think, initiative, a unique initiative that IIP had started, and we are very glad we are a part of this Sandhya Pathshala in this month. I just want to mention regarding our case that sometimes we are very much eager to diagnose a very difficult case, but because of the financial issue and sometimes I mentioned that we have said MOG antibody, but we cannot do sometimes very nominal thing to diagnose a easy case. Just because of our focus, we sometimes focus on only diagnosis, but we are actually we miss the proper way how to diagnose the case. We have said sometimes copper and all that, but it's wastage of money. Definitely, I agree about that part. And I think every student should take part in the Sandhya Pathshala, and to be honest, that it's a really good initiative. I am really enlightened by the good discussion. Thank you to everybody.
Any comments from anybody? Joshodhara?
So that was a very good discussion, madam and sirs. Any final comments?
So, Dr. Arijit?
All I can say, I thoroughly enjoyed the last 1.5 to 2 hours.
And
So
we
I
are on
request
time, sir.
Okay.
We finished
So-
within time.
So I request Professor Kalpana Datta to conclude the session, and we'll be again having the same Sandhya Pathshala in the next month in September.
And thank you, Dr. Shapun. Thank you, the experts, Dr. Arjit Chatterjee and Dr. Apurva Ghosh, who you people are we are enlightened by your knowledge and all. And the mentors also, they have done full justice to their students, and the presenters are wonderful. Really, and the secondary PGT and the Bonnie as a postdoctoral PGT has done a wonderful job and the presentations. And I really thanks all the audience. It was a totally interactive, lots of questions coming up. So I'll request all the who are here, I'll request please encourage your PGTs to present many more cases, and please volunteer that your PGT will can present any case, and let me know what type of cases. Like we did all different systemology like neurology, nephrology, pulmonology, different types. So anyone interested in presenting case, please let us know, and we'll have the next session in the next month in the last Sunday from 8 to 10. And thank you for joining and making it a
So
wonderful.
I can suggest one thing, because Dr. Birendra is there. I met Birendra in 2019 in Milton Keynes. So we can have IIP has got an overseas branch also. So they can also present, and we can learn from them how they present and in the what level we should present. So Birendra, please take that initiative.
Yes, you all
Thank
are
you, sir.
welcome.
Thank you, sir. I'll have a chat with you about this. No problem.
Okay.
Thank you.
Okay.
Thank you.
Thank you.
Thank you and good night.
Thank you and good night.
Everybody.
Thank you.